Welcome everyone to tonight's online presentation from the Royal Society of New South Wales. My name is Susan Pond and I'm honoured to chair this meeting as President of the Society. We have tonight the open lecture to be presented by Scientia Professor Kaarin Anstey. I acknowledge the traditional custodians of the lands on which each of us is living and working and viewing this online meeting. I pay my respect to elders past, present and emerging. Tonight I welcome, as well as Professor Anstey, who I introduce in a minute, George Paxinos, who will introduce himself as an esteemed Scientia Professor at the University of New South Wales, who will conduct the Q&A, and Slade, who is chair of our program committee, council member and member of the Society's executive committee. Welcome to Kaarin, particularly, who is a Scientia Professor, Fellow of the Society, Fellow of the Academy of Social Sciences, and Fellow of the Academy of Health and Medical Sciences. Kaarin is Deputy Director of the ARC Centre of Excellence for Population Ageing at Neuroscience Australia, University of New South Wales, Sydney. Importantly, Kaarin was the winner of the Society's award in the Social and Behavioural Sciences in 2023, the first year that the Society has made this award. She was awarded this for her world-leading research and policy leadership nationally and globally on cognitive resilience in ageing and prevention of dementia. Kaarin is a member of the World Dementia Council, an international charity that draws together experts from across the world to defeat dementia. Her topic tonight, Brain Health Equity, a new frontier for healthy longevity, is close to the hearts and brains of all of us. Welcome, Kaarin.
Well, good evening, everyone. I'd just like to start by acknowledging the traditional owners of the land here at the University of New South Wales, that's the Bedegal people, and to pay my respect to elders past and present, and to extend that respect to any Aboriginal and Torres Strait Islander people who are joining us this evening. So I'm talking about brain health equity, a new frontier for healthy longevity. I'd like to start with a quote from two very well-known women neuroscientists, Denise Park and Patricia Reuter-Lorenz. They said, at present, it is fair to say that neurocognitive frailty is the biggest threat to successful ageing in our society. And this is, in my opinion, true. I'm going to explain that now in the rest of the talk, but also bring a much more social determinants of health perspective to this wider topic. I'd just like to start by describing what happens in normal cognitive ageing. So this is from data from a cross-sectional study. It was actually from the article by Park and Reuter-Lorenz. And it shows you that we have two types of abilities. We have those that increase, that's the world knowledge depicted in the orange colours and red, and they increase over the adult life course. So along the x-axis here, you have age, and you can see that these abilities improve, and this is why often we become better and better at our jobs. We accumulate a lot of general knowledge and expertise. But at the same time, we have a decline in many other cognitive abilities over the adult life course, and they are abilities involving novel problem solving, processing speed, and memory. Now, this is cross-sectional data, so it actually confounds age differences with cohort differences. So it's good to look at this in longitudinal data. And we have longitudinal data from an Australian cohort, the Path Through Life. I'll be referring to this cohort several times during the talk. So at baseline, the age of these cohorts, we actually had three sub-cohorts. So at 20 to 24, 40 to 44, and 60 to 64. And they were followed up 4 times over 12 years. So we're able to look at how memory changed within the cohorts over 12 years, and they were also able to compare how that differed between the cohorts. And what you can see is that in the 20s, the average member of the cohort could remember about 8 words from a 16-word list, which was the test that was administered to these participants. And their memory for this actually improved a little bit over the 12 years of follow-up. In the middle-aged participants, we see a drop in performance, but it's fairly stable. And then in the older participants who are 60 to 64 at baseline, there's a lower level of performance when they commenced in the study. But what's really important here is to look at that trajectory. And in the late 60s, we start to see a drop-off in memory performance across the whole cohort. So the cohort had about 2,500 participants at baseline. Now, there's a lot of individual differences in these data. So what we find is, we'll still have a few people in our older cohort who can actually recall 16 words in the test, but these are, on average, the population is declining. So this is what we would call normal cognitive aging. We saw a similar pattern with delayed recall. That's when people have a break between the initial memory test and the recall task. We also looked at our data for other cognitive abilities to try to understand what normal cognitive aging looks like in Australian data. And what's noticeable is also the sex differences that we see. So in the previous slide, we saw that women had better memory performance than men at all ages and all occasions of assessment. And on this slide, we can actually see that men actually have faster reaction times than women. And so men are the straight line, and a higher score on this is slower. So men actually have faster consistently across all ages and cohorts. They're also faster at a coding test, a digit symbol modality test. Again, you can see the trends in aging here. So in reaction time, young adults are fastest, and we slow a bit in midlife, and then there's greater slowing in later life, and that's the same in choice reaction time. In this coding task, the symbol digit modalities test, we see quite significant age decline here. So this is the raw score on the test. In the 20s, they were getting about 65 at baseline, and the 60s when they started were scoring 50. So there's quite a big difference in the score, and then that starts to decline. And then we have this test called Spot the Word, and we can see improvements in ability over time. So we see a bit of learning, but also we see the age differences with the oldest cohort actually performing the best on this task. And that's that verbal ability that I showed you in the first slide. So that's reflecting those other results from the United States. So our data is very consistent with international data, but what I'm showing you is that there is normal cognitive decline in the population over time and age. So if we just step back and look at the big picture of cognitive aging, where we'd like to all be is aging normally. So in the normal population, we do see some cognitive decline. There's a lot of redundancy in the brain and in our cognitive ability. So, if you can still retain all of your function even with some decline. So it's only when that decline hits a threshold and you're actually impaired in your daily activities that it becomes clinically significant. So where we'd all like to be is normal aging. But we do have some people who move into a preclinical stage where they're aware that there's some more significant change going on. We may be able to see some changes on brain scans, but clinically, if we did some tests, we can't find any impairment, and people in this stage are still functioning very independently in the community. They may stay like that for their entire life. They do have an increased risk of progressing to dementia. We then have a stage called mild cognitive impairment, which is clinically significant impairment in at least one cognitive ability that's of concern to the person or their family. But people with mild cognitive impairment are also independent in the community, and they may stay independent for their whole life. They also, though, have quite a significant increased risk of dementia. This is usually seen as a preclinical stage. We also see some people revert, though, from MCI back to normal aging. So it's an in-between stage. And then we have a clinically significant decline in cognitive abilities. and known as dementia or major neurocognitive disorder. And there's different stages of that, from mild through to severe. So what we're interested in, at the population level, is obviously keeping as many of us as possible in that top normal aging range. So we want to reduce the decline at the population level, shift it as much as we possibly can through cognitive enhancement and prevention of risk factors. And so there's an enormous amount of research and work that's gone on in the last 15 to 20 years looking at this. So part of the reason we have the decline is due to diseases, neuropathological conditions such as Alzheimer's disease. So when I refer to dementia, that's really an umbrella term for a number of causes of neurocognitive decline. And the most common is Alzheimer's disease. In Australia, about 65% of dementia is caused by Alzheimer's disease. So a lot of that cognitive decline in aging is due to the accumulation of neuropathology that we can't, obviously can't see, except we can now measure these through advanced imaging techniques and through plasma biomarkers. And what's become important in our understanding over the last, say, decade is how early the changes start to occur. So in this study, the authors looked at life course neuroimaging data to try to work out when people on a trajectory towards Alzheimer's disease started to show changes in their brain volumes. And they were able to pin it on midlife. So when they looked back retrospectively and modelled the trajectories of people who ultimately developed Alzheimer's disease and mild cognitive impairment, they could see changes. So the trajectories start to split in the 40s. They could also see changes in other parts of the brain, the lateral ventricles and the amygdala. Hippocampus is particularly important because that's associated with episodic memory, which is the hallmark of Alzheimer's disease is short-term memory loss, and that's related to hippocampal volumes. So I think what's happened is we now understand that a lot of change is happening in the brain before there's any symptoms. It's happening decades before diagnosis, but that also means that there's a big window of opportunity to modify trajectories that people are on. So there's been a lot of emphasis now on how can we modify the trajectory and slow this down. Just to expand on the model, we're linking biology to risk factors. The idea behind a lot of the work that we do in dementia prevention, normal cognitive aging now is summarised in this model, looking at the evolution of the biomarkers over time. And I think if you just focus on the bottom part, the idea is that if you have healthier lifestyle and reduce risk factors, you will delay the onset of significant cognitive impairment and dementia. But if you have high risk factors, that will occur earlier. And you may never develop, obviously, it's not like everybody is going to develop dementia. So it's for people who are on that trajectory, who have those biomarkers. There's quite a lot of modifiability here. So this is what we're really interested in when we're looking at brain health and what we can do as a community to improve it at the population level. So how big is the problem of cognitive impairment and dementia? It's actually quite significant. So if you look at the figure on the left here, this is data from the US Health and Retirement Study. We don't actually have a national prevalence study of dementia in Australia. So if you look at the dark blue bar, show you the prevalence of dementia in the United States by 5-year age groups, and you can see that it increases with age. The biggest risk factor for dementia is chronological age. And it's quite high. So in the late 80s, about 25% of the population has dementia. What's even more concerning to me is this yellow bar. So what I've done is I've plotted both MCI and dementia and added them together. So the amount of mild cognitive impairment is actually almost stable all ages. But when you add these two together, in the 90s, you have over 60% of the population with either MCI or dementia. And in the late 80s, you're having over 40%, or in all of the 80s, and in the 70s, you've got 30%. So these are really, really high numbers. And there's other research, another way of carving up the data from the United States shows that over the age of 70, 1 in 5 adults has a mild cognitive impairment. So it's highly significant. Now, in Australia, we currently have 421,000 people with dementia. That's an estimate because, as I said, we don't have national prevalence data. And that's projected to increase to over 800,000 by 2054, with if nothing changes, and the current projections are based on our prevalence rates now. So I wanted to look now at the risk factors and what we can do to modify this. So there's many risk factors for cognitive decline, Alzheimer's disease, vascular dementia, and all-cause dementia. And so we need to sort of find a way of conceptualizing the whole lot. A systematic review my team conducted in 2019 found about 35 risk factors. We divide them into non-modifiable and modifiable. And then within the modifiable, I would like to further divide them into those that could be addressed through public policy, that have a social component, and those that are more individual level risk factors. Noting that individual risk factors can also be addressed through population and social policy. So I'm going to start talking about the non-modifiable briefly, and then I'll talk about the modifiable. The main modifiable risk factor that's of interest for many of us is the genetic risk. This is what I often am asked about. So there is a genetic risk factor for Alzheimer's disease. It's the apolipoprotein for E4 allele. It's present in Caucasians. It's present in about 1 in 4 people. So it's actually highly prevalent. And it increases, if you have 1 copy, it increases your risk of Alzheimer's disease by 3 times. And if you have 2 copies, it increases your risk by 5 to 8 times. It's not necessary nor sufficient to develop Alzheimer's disease, though. So Alzheimer's disease, this is talking about late onset dementias that are occurring, say, over 70 or over 65. It's multi-causal. There's a whole lot of factors that increase risk. There's other types of dementia. So there's Lewy body dementia, there's vascular dementia, frontotemporal dementia. They also have genetic risk factors, but they're less important than the ApoE. They account for less of the heritability. I'm now going to talk about the relationship between genetics and lifestyle, because a lot of people want to know, well, how important, is the genetic versus the lifestyle? If I have the gene, obviously 1 in 4 of us has a risk factor gene for Alzheimer's disease. Does that mean there's no point doing anything, or should I, do even more? So basically, the message is there is modifiability even if you have the genetic risk. And a lot of studies have looked at this. This is a meta-analysis which synthesized data across studies of about 200,000 people. It found that both unfavorable lifestyle and high genetic risk were associated with higher dementia risk. And I've just circled the group here just so you can focus on these results for people who had high genetic risk of dementia in this meta-analysis. So those that had a favourable lifestyle, their hazard ratio for dementia was 1.95, which means they had a 95% increased risk of dementia compared to people without a high genetic risk. But those that had an unfavourable lifestyle, their hazard ratio was 2.83, so much higher. So they concluded that, even if you've got the genetic risk, there's quite a strong component of lifestyle. So another way of putting a handle on, the contribution of lifestyle is looking at what we call population attributable risk. And the Lancet Commission has done this in a very important report published in 2020, and they estimate that about 40% of cases of dementia are attributable to modifiable risk factors globally. Now, this isn't talking about individual people and whether 40% of their risk is attributable to modifiable risk factors. It's talking about population level data. So it's very difficult to specify for an individual. I'm just going to talk a bit more about this Lancet Commission report because they've outlined 12 risk factors that they focus on as the most important. There is some difference in opinion on the most important risk factors. The evidence is being published all the time, so the field's actually updated quite a bit since 2020. But this is a really helpful report because it divides the risk factors into stages of the life course, and we need to take a life course approach to tackling this. So in early life, it's low education is the biggest risk factor. And then in midlife, we have hearing loss, traumatic brain injury, hypertension, alcohol, and obesity as all those risk factors. For late life dementia. And then in late life, they identified smoking, depression, social isolation, physical inactivity, diabetes, and air pollution. The World Health Organization has a slightly different list. They also identified high cholesterol in midlife and poor diet as risk factors. And as I said, there's been a lot more published since then, some of which I will talk about. I'm going to talk more about individual risk factors now, just to run through, and this includes some additional ones to what the Lancet Commission included. So of the medical risk factors, there's diabetes and heart disease, both increase the risk. They're very well established. Within heart disease, atrial fibrillation is now included in some of our dementia risk assessment tools. Depression, stroke, estrogen, high cholesterol in middle age, kidney disease, high blood pressure in middle age, obesity in middle age, head injury, they're all associated with an increased risk. And two emerging risk factors are viruses and sleep disorders. So there's a lot of research starting now on looking at infections and viruses and their role in neuroinflammation and how they accelerate the accumulation of neuropathology. So I think that's an area we'll see a lot more clarity in over the next 5 years as more and more is published. Sleep disorders is another area where we're seeing more published and we'll gradually get a more clarity on the findings there. Just going to discuss a few of the medical risk factors, ones that I think really deserve highlighting. And I think depression is probably the one that is perhaps the most important to highlight because it's under-recognised, and yet a lot of the work we've done has shown it has the biggest effect size. This meta-analysis that we conducted in 2015 pulled 35 studies and found an increase that late life depression was associated with an increased risk of late life dementia using very standard measures. There's now systematic reviews and evidence showing that midlife depression is also associated with an increased risk of late life dementia. Another very interesting risk factor relevant to many of us is estrogen. And there's a lot of focus on estrogen because whilst overall worldwide, if you look at the rates of dementia globally, they're sort of similar for men and women if you control for age. We actually see high rates of Alzheimer's disease in women, and we see a lot more dementia in women than men because women live longer than men. But there's definitely an increased prevalence of Alzheimer's disease in women, and we don't understand why. And so a lot of people are looking at hormonal factors, including menopause. And this study looked at endogenous estrogen, studied by Fu et al., and that compared women who had earlier menopause, so menopause before 45, and compared them with women who had late menopause, and found that the women who went into early menopause did have an increased risk of dementia, Alzheimer's disease, all-cause dementia, Alzheimer's, vascular and disease, and cognitive impairment. And the obvious question then is, well, does HRT reverse this risk? And unfortunately, at the moment, for the general population, it's different in specific clinical groups, but for the general population, we can't say at the moment. There's been, obviously, theoretically, it makes sense, but there have been both positive and negative findings from cohorts and clinical trials, and that's partly methodological. Some of the older trials used very different types of estrogen, so equine estrogen from horses, for example. They've used different dosage, and there were different side effects, an increased risk of breast cancer from some of the studies, but they use different estrogen. And there's so many factors that need to be controlled for. So things like age at which the dose is started, duration, type of estrogen. So Again, this is an area that is under research, and we would hope that in the next few years we'll get a clearer idea about estrogen and long-term brain health. Blood pressure, I also thought I'd mention, because it's modifiable, it's been shown there's a consistent relationship between middle age, blood pressure, and late life incident dementia. But there's also a treatment for antihypertensives, and it has been shown. So unlike HRT, in this case, we do have evidence that treating blood pressure with available antihypertensives is associated with less cognitive decline compared to people who have untreated blood pressure. What's interesting though is it seems to be midlife blood pressure, not late life blood pressure, that's important. And if you look at the bottom half of this slide, just along the very bottom row, we've got the hazard ratios for adults over 65 in this systematic review, and they did not find none of these were significant, but the hazard ratios for having hypertension in middle age were significant. The other thing that people are looking at is variability in blood pressure, and that seems to also be associated with an increased risk of dementia, as well as the cumulative blood pressure. So the length of time that you've had hypertension increases your risk. Sleep disorder, as I said earlier, it's really a new area of investigation, and of all of the sleep disorders, the one where the evidence is strongest is sleep apnea, and we now believe that is a risk factor for cognitive decline and dementia. But good news again is that there is an effective treatment for sleep apnea. So there'll be a lot more work, I think, coming out on different sleep disorders and their relationship with brain health. It's often been very difficult to disentangle causal relationships because a lot of neurological and neurodegenerative conditions also have symptoms of sleep disturbance. I'm now going to turn to the lifestyle risk and protective factors, which are something that all of us can participate in terms of protecting our brains. I'd include diet, physical activity, smoking, social engagement, cognitive stimulation, and alcohol consumption here. So I'm just going to talk about a few of the key ones again. This one is diet. So there has been a lot of research on diet and brain health, and it wasn't included in the Lancet Commission, but the World Health Organization recommends a healthy diet to reduce risk of cognitive decline and dementia. So meta-analyses have shown that the Mediterranean diet is associated with a reduced risk of Alzheimer's disease. We've never found that in our Australian data. We looked at this, but we have found associations for the MIND diet. So the MIND diet is a form of Mediterranean diet, but it was developed by Martha Morris in the United States, and she actually looked more, so when the Mediterranean diet was developed, that's more of a cultural diet. It wasn't specifically designed to protect the brain. So it wasn't, it's more of a heart health lifestyle diet, and it's based on a region of the world. The MIND diet was actually developed with the goal of trying to identify dietary patterns and foods that have neuroprotective properties. And so Martha Morris looked at all of the different foods and identified those and scored them according to their neuroprotective properties. And it's actually a version of the Mediterranean diet, but it really emphasises green leafy vegetables to be eaten every day and berries from the fruit. So here is the scoring of the diet on the slide. You get points here according to how well you adhere to this diet. So it does include drinking a glass of wine a day, and that has been controversial, and so that's changed. I'm going to talk about alcohol later in the talk. Yes, it's got low processed food, cakes and pastries, and a high fresh fruit, vegetables, fish, nuts, berries. We looked at the MIND diet in Australia in our cohort study that I told you about earlier. We looked at in older adults and who'd been followed for 12 years. And what we found was that the older adults had a reduced risk of cognitive impairment and dementia for the MIND diet, but not the Medi diet. And this is pretty exciting. It was the first time the diet had been shown to reduce risk of cognitive decline outside the United States and the original group who developed the diet. And it reduced the risk by over 50%. So it's highly significant. And this is on that cohort who I've presented the data from them earlier. We used the CSIRO food frequency questionnaires, which was also good because it was using Australian developed measures that reflect the sorts of diets that Australians eat. And I want to talk about physical activity. I'm sure many people have already heard that physical activity is good for brain health and it reduces your risk of dementia. It's been talked about a lot. So there's many systematic reviews. So I'm just really going to tell you the key newer findings around physical activity. This systematic review was published in 2023 and it synthesised a huge number of, or 29 cohort studies, and it showed that physical activity reduced the risk of Alzheimer's disease by 15%, up to a follow-up of 15 years. So the benefit starts to wear off if you stop physical activity. But the key finding here was that the effects were for moderate and vigorous intensity physical activity only. The reason that is good to see is because it actually is consistent with another systematic review of the randomised controlled trials, which were conducted in community dwelling adults aged 50 and over. So this systematic review looked at aerobic training, resistant training, and multi-component training. And it also found that high intensity physical activity and moderate intensity was beneficial, but not low. So I think when you start to see that triangulation across different types of studies, it really is good, enables us to give firmer recommendations on physical activity. They found all types of physical activity was beneficial except for yoga. And when I say that beneficial, I mean beneficial for cognition. So they were looking at cognitive outcomes, not dementia, in these studies. I want to talk about smoking. So I don't think it's any surprise now that smoking is associated with an increased risk of dementia, although back in around about 2000, there was a stage when people thought smoking was actually protective against Alzheimer's disease. So, you know, now it's well established that it increases the risk of vascular dementia, Alzheimer's disease, all-cause dementia. What's new is that there's emerging evidence of the benefits of giving up smoking. So this paper was published last year from Korea showing quitters had lower rates of incident dementia in this cohort study. And there's also Australian data showing that adults in their 70s who've given up smoking have less brain atrophy and better cognition over 2 years. So it's never too late to give up smoking. I want to now talk about alcohol. So alcohol has been quite a controversial topic in the field of brain health and risk of dementia. We have conducted many systematic reviews and also looked in our cohort studies here in Australia, and we always find that light to moderate drinking is associated with a reduced risk of dementia, so by about 20 to 30%, and also less cognitive decline. So the reason this is controversial is because these are observational studies and our comparison group is people who don't drink. So it's unclear if drinking is protective or abstainers have increased risk. And so that's been debated, but when people have tried to look at that in other studies, they haven't, and even adjusted for it, they still find a benefit of light to moderate drinking for cognitive aging. The protective quantity seems to be about 1 to 2 drinks a day. Now, there's a lot of caveats here because the World Health Organization says that there's no safe level of drinking and alcohol consumption does increase the risk of some cancers. So in making any recommendation about alcohol consumption, we need to consider all risks, and we would always adhere to the National Health and Medical Research Council guidelines. Now, I'm just going to talk about cognitive engagement and stimulation, which I'm sure with this audience, you're all very, very cognitively stimulated and you've had complex careers and occupations. But there is a lot of evidence showing that there's a benefit of cognitive stimulation for maintaining cognition and preventing late life cognitive decline and dementia. This study looked at the combined effect of education and cognitive stimulation in 7 population-based cohorts, combining over 100,000 participants. And you can see that there's a bit of a dose-response effect here. So people that had high education and a highly complex work role had the lowest risk of incident dementia, and people that had both a low level of education and low cognitive stimulation in their job they were the comparison group with the highest risk of dementia. Now, this has been seen over and over again in the literature, but it does bring into play a lot of these social determinants of health, because there's a lot of social and structural reasons that impact the education one actually has and has the opportunity to receive, but also then the education itself then provides other opportunities for more cognitively complex roles and brain health. So there's been a lot of more recent work looking at how things like race and ethnicity interact with these factors. So as I said, there's a lot of interest now on cognitive and occupational complexity, cognition and brain reserve. So looking at what we do in our jobs as well as what we do in our leisure activity. And I thought this is a particularly interesting study. It's been published also last year, looking at different types of occupational complexity. And this group found that working with people was protective against decline in cognitive reserve, and compared to working with data or working with things. So it's jobs that involve a lot of negotiation and people management seem to be protective. And what's interesting is that this result has also been reported by So et al. In another very ethnically diverse cohort from the United States in the same journal, Alzheimer's and Dementia. So it does seem to be coming up as a consistent finding when we're starting to tease apart, well, what aspects of occupational complexity are neuroprotective. And I think this is an area, again, where a lot's happening, and we're learning more and more about how to protect the brain through occupational stimulation. So now I've talked about a lot of the risk factors. I want to now try to look at some of the broader social determinants and the risk and protective factors that can be influenced by policy. One of the big ones is race and ethnicity. So there's very big differences which are related to race and ethnicity in prevalence of dementia in the United States, where most of the research has been done. And this study looked at Black, Hispanic, White and other groups, but they've also broken it down and looked at Asian and other ethnic groups. This is seen in other countries as well. So there's sort of general trends which are often then accounted for by other systemic risk and disadvantage, or lifestyle, diet, hypertension, etc. In Australia, we see dementia prevalence is 3 times as high in First Nations Australians compared to the general population. And we also see higher rates of disadvantage and risk factors in First Nations Australians. So there's also broad sex differences in the prevalence of risk factors. So we reported the difference here in that cohort, the Path Through Life study, a couple of years ago in scientific reports, and quite significant variation in things like head injury, which is a risk factor I haven't talked about, but it's a risk factor of dementia, the differences in vigorous activity, some favouring men, some favouring women. And then these risk factors then interact with those other structural factors like ethnicity, education, race, etc. Education, as we know, is the biggest risk, globally accounts for the biggest risk of dementia, low education. And this has probably been known for the longest apart from age. Education has always been recognised as a risk factor for late life dementia and associated with cognitive decline. So higher levels of dementia, education is shown to be protective in this meta-analysis on the left. And part of people are now starting to say, well, what is it about education? What about the quality of the education that you had? And they're starting to put forward models about how education leads to occupational complexity, and there's an interaction there. I'm just showing that to illustrate where the thinking is going. And then people have then looked at, in the United States, socially disadvantaged areas, segregated schools where they're being segregated on the basis of race, poorer levels of education, and built more complex models about the social determinants of health, how that impacts education, impacts occupational opportunity, and the complexity that you then have that influences your brain development and your ultimate chronic disease risk factors and risk of dementia. So there's more work showing that early life and late life socioeconomic status impacts your risk of cognitive decline. This work was from, again, the United States, the Health and Retirement Study. And again, it showed that people that had higher socioeconomic status at both early and late life had the least cognitive decline, and people with the most disadvantage had the fastest and most cognitive decline in the follow-up period of this study. In the UK, in the English longitudinal study of ageing, they have looked at their cohort over 6 years according to levels of wealth. They divided their sample into tertiles in terms of their wealth, and showed that risk of dementia was highest in the low wealth group. So it's just multiple studies now, agreeing and looking at this issue from different perspectives, picking out different social indicators. In Australia, we looked at current financial hardship in our cohort, and we found if people were unable to heat their home, were going without basic needs, and had reported hardship, their cognition was poorer at that time. This is contemporary hardship and contemporary cognition. There's also evidence of environmental risk factors that affect cognition and brain aging, and then risk of dementia. Again, and these can be also interrelated with the socio-economic factors, with people from lower socio-economic backgrounds often having to live in places that are more polluted. But in this study from Canada, they looked at just how many metres a person lived from a main road, and that was the variable in their study, and found that if you lived close to a very traffic-heavy road that was quite polluted, you had an increased risk of dementia. So once this was adjusted for all sorts of covariates, the effect size was actually quite small. It went down to 6%, but it was significant nevertheless, and it was associated with increased risk of Parkinson's disease as well. But this has been now shown many, many times. So air pollution is now very well established as a risk factor for late life dementia. It was actually in the Lancet Commission in 2020, and it's been linked to individual subtypes of dementia, such as Alzheimer's disease, Parkinson's dementia, etc., as well as all-cause dementia. And the particle that's received the most attention is the PM2.5. That has a relative risk in this study of 1.13. Risk factors that I've discussed are actually cumulative. So I just wanted, it means that the more risk factors you have, the more your risk of dementia increases. And we showed this in a systematic review here. And obviously you can see how this all compounds. So if you're socially disadvantaged, your chance of having these risk factors increases because of less access to healthcare, less education, not living in a clean environment, etc. So all of this adds together to something that we would call to sort of a model of brain health equity. And this idea was published in 2022 actually in a cardiovascular journal, Circulation, and it's being talked about a lot by advocacy groups, much more than academics. And the idea here is that there are fundamental structural determinants that impact a person's probability of having these risk factors, and their racism, economic opportunity, and your social and community context. And I would argue that things like access to preschool education and good quality food for young children is really critical here. We're looking at life course development of healthy brains for optimal aging. And then in midlife, it's things like having secure employment, having access to ongoing education and healthcare, and living in a good neighbourhood. And then late life, there's other factors that impact, or modifiable risk factors related to physical activity, social engagement, and so forth. So, as I said, it's mostly been the advocacy groups that are talking about brain health equity. There's the American Association of Retired Persons. They've set up the Global Council on Brain Health, and they've published a big report on this. And there's US Alzheimer's, again, for brain health equity as well. And so I think people are starting to say, well, we now know a lot about optimizing brain health and reducing risk of dementia, but we can't do everything at the individual level. We need to look at some of those structural drivers. So we need to take a population health approach. And we've been arguing this in other papers for some time. We need to look at all of the sectors of influence when we're looking at population health, and we also need to look at health inequalities and reduce those to improve the health of the whole population. Reducing the risk of some of the drivers of chronic disease like smoking, physical inactivity and air pollution and head injury is also cost effective. So there's been some work trying to estimate the strategy. So if you're looking at a population health approach to brain health, you'd bring in policies, taxes, laws, schemes that would, reduce smoking and build, environments that support physical activity, remove tax from healthy food, but tax unhealthy food. And when we've tried to look at the economics of this, there are economic benefits. You have to take a sort of whole of government approach because there's costs in some areas, but ultimately the long-term benefit is cost effective. So that's bringing it all together. So to conclude, we are expecting very high rates of mild cognitive impairment and dementia due to our population ageing, increased life expectancy, and some of these emerging risk factors. Approximately 40% of the risk of dementia is attributable to modifiable risk factors. We need to take a life course approach and reduce risk across multiple domains. And it's one thing for us individually to look at our own risk factors, but we need to focus much more on these social determinants across the life course where we can shift the entire population level of risk. Risk reduction for promoting brain health is cost effective. I didn't have time to go into all of the cost effectiveness work tonight, but it also has many benefits for ageing well, but we need both the individual and the population level approaches. Thank you. I'd just like to acknowledge my funding, and also if you are interested in assessing your own risk of dementia, we developed a risk assessment tool called the Cognitive Risk. It's free, and the URL and QR code are there. You can go online and assess the modifiable risk factors that you have and get evidence-based advice there. Thank you.
Kaarin, thank you for this panoramic view of the risk factors. So you would say that the ancient Egyptians did not get it quite right when they heedlessly discarded the brain in funerary practices and sent millennia of pharaohs brainless to their afterlife. I was very pleased to see some of the factors that can delay dementia. Olive oil. And if I may say, Australia has very good olive oil. Indeed, is getting some prizes, international prizes. I was disappointed that yoga, if I understood well, is not coming up positive, not yet anyway. And I just wondered whether Pilates might, since that's now gaining popularity. It is really impressive how the problem that 3 times the natives have 3 times the risk level, and that low wealth is a predictor. At the same time, that to have excessive wealth, this could be a good point for the public to know in making those structural changes, which you said are required. I am looking now, I have some in the chat, a few questions. Okay, where are the questions? But what's, no? if one combines your findings on smoking with all the other evidence, we have the disastrous effect of smoking. You would think that tobacco companies would stop pushing their products. That they do not do so makes them bad corporate citizens. What do they do as what do they do as they do? And that's from Peter Baum. That's a question to you.
Thanks, Peter. I agree with you. There's no logic to pushing smoking. The health costs are enormous. I don't know why they do. Obviously, there must be a profit motive, and some people believing that we deserve individual choice. So it's weighing up, individual choice against the actual cost to the community. I would like us to see cognition as a form of social capital. So by promoting brain health for the whole community, we're actually increasing our overall capital, cognitive, intellectual capital with an aging population.
So I have another question here. Does the forward estimate for AD take population increase into account?
Yes, so the numbers that I quoted, the projections for Australia, they're just purely based on demographic estimates of population ageing. They're not, so they don't take any change in risk factors into account. It's just a purely demographic estimate. So the reason we're seeing much more dementia is because we have an ageing population. People are getting older, so age is the biggest risk factor for dementia.
Yes, and from Vince Di Pietro, does culture matter? Our lifestyle is very different to many, including the US. So is there somewhere you believe we should be investing to acquire the data and tailor it to be more accurate in our Australian culture?
Absolutely, culture matters. Cultural practices, and of course we have an incredibly culturally and linguistically diverse society in Australia, with 1/3 of Australians born overseas. And so we're still reliant, we're relying a lot on data from the United States and Northern Europe in my field, because we don't have a national prevalence study for dementia. So this is actually another area that I'm quite an advocate for, is that we need much, much better data in Australia that's relevant to our own culture and our own complex ethnic and cultural makeup. And then we can also drill down into the nature of the risks and the lifestyle habits, the exposures that we have that are unique to Australia.
And our President Susan Pond asks your views about the role of stress in the development of dementia.
That's a great question. Yes, stress has been studied. Now, and I often am asked about stress. It's actually a really difficult area to study because everybody gets stressed. Stress is very common. But some of the work on people who have extremely stressful lives, so they've looked at things like, women who are caring for disabled children and shown that they have shorter telomeres and poorer mental health outcomes. And there's exposure, so people that have experienced PTSD from usually veterans who've been in very stressful situations, they are at an increased risk of dementia. But it seems to be at that extreme end because it's very hard to sort of find a cutoff when we all feel stressed a lot of the time. So, but there's also a lot of work on childhood stress and trauma, how that affects brain development, and that ultimately will increase risk of neurodegeneration as well.
Based on all of this, how do we get the government to adopt the kinds of solutions you propose? That somebody asks.
Someone I wish I knew the answer to that. I feel like I need help. I want people to work with me to do the lobbying. I'm actually vice president of the Global Council on Brain Health in the United States, and they're an advocacy group in the United States, and they do lobby the White House. we need to be doing the same here. I mean, we have Dementia Australia, but I think that we need to be tackling. It's not just a health issue; it's the whole of society, and we need to understand the impact because we have this aging population. It's going to impact all of us, and it's also the benefits are enormous. So we need to, I guess, lobbyists. There's lobby groups are sort of experts at getting into Parliament House and talking with politicians, as well as through the sort of typical consumer organisations. I guess we need multiple groups working together to do this. And often as an academic, that's not what our skill set is. Our skill set's, in research, and yet I guess it's got to a point where I feel we do need to be working with the other sectors to bring about change. But if anyone has suggestions of how to or has examples of how they've been able to change policy, I would love to talk to you.
The French had a revolution on liberté, égalité, fraternité. The issue of égalité seems to be relevant to you, to all of us.
Yes, I think it is. And this is sort of a really good argument for publicly funded healthcare and public education. I mean, do we want to end up in a society where we have, with older people, we're going to have huge differences in health outcomes, not just in brain health, but all health outcomes in aging, because the risk factors accumulate over the life course. So we already have differences in life expectancy, but we're going to have differences in the chronic conditions and then in the neurodegenerative conditions as well. So we do have to think about what sort of society do we want to live in. And some of the things, improving education, which would be advocated by a lot of people for other reasons as well, it seems to be a good place to start, in my opinion. I feel like, as I said, I think early childhood and public education, investing in the brain health of our future is really important.
If not antenatal,
yes,
prenatal and antenatal care. I mean, you are marinated for 9 months in a certain environment. And Susan asked, what are the specific differences in risk factors for dementia, our indigenous population compared to the overall population? Is the incidence of dementia lower in Greece on an age-related basis? On the last one, I'd say if the diet has some benefit to the olive oil in Greece, the smoking rate is in males of military age, some 20 years ago that I had some data, it was 100%.
Right. So I just want to go back. So did you say the first question was about our Indigenous population?
Yes.
So we see similar increase with age. We see similar distribution of the types of dementia in First Nations Australians, but the risk factors are higher. We obviously have lower rates of school completion. So like I said, globally, the biggest risk factor is low education, but also just intergenerational trauma, disadvantage, all of those risk factors that we hear about and talk about, and poorer access to health, good quality healthcare and housing and environmental exposures. First Nations Australians, not all, but some communities are really more disadvantaged.
One of the things that psychologists know is that motivation itself is environmentally influenced. And you have the situation, you say, they don't want to help themselves. Sometimes of the disadvantaged groups, but itself motivation is environmentally influenced. So if you start with environment that's not conducive to motivation, then your motivation will not be as high as the other group that had an advantage to start with.
I think what we would say is that with public health, it shouldn't be down to individual motivation. A lot of it is structural. So a a lot of, so some choices are, individual, but a lot of it relates to things like having access to, access to purchasing healthy food at affordable prices, or access to high quality schooling for your kids, being able to afford to live in an area with good public schools or afford private schools. They're not choices that the child is making. They're the choices that you're sort of born into. So I think the bigger drivers here across the population level that we need to be looking at are those sorts of social determinants. And individual motivation, it's sort of like, it's a very complex, in the whole context of this big picture, it must come in, but I don't think that's probably the area where we're going to make the biggest difference.
Right. Someone asks, you mentioned the issue of midlife hypertension. Why do you think that midlife issue has an impact later on?
That's a good question. So we're not quite sure why. I mean, part of it's the length of exposure. So obviously the sooner that you have, the earlier you have a risk factor, the longer you're exposed to that risk factor. So we do see that is true, but we also have the same phenomenon with obesity and high cholesterol. It's only when you have those risk factors in midlife that you have an increase in late life dementia. With blood pressure in particular, I think I don't fully understand it, because I think there can be some physiological changes in the way blood pressure affects the brain, and there are some natural changes in the way blood pressure changes with age. So the other problem with a lot of this data is it's epidemiological, where we take peripheral blood pressure. We're not looking at cerebral blood pressure. So these are often very blunt measures that we've found, but it is a very, very well replicated finding that it's midlife and not late life.
Yes, I heard that the 80-year-old cohort today has fewer in percentage dementias as 50 years ago. If that is true, well, somebody, a gerontologist, said that to me from the UK. And I'm glad that he was telling me the truth. And then he attributed that, guessing, to the emphasis the cardiologists have placed on the health of the heart. So they have lost really that glory of the heart being the place where love is manufactured, but they have done something good for all of us.
Yeah, so in high-income countries, we have seen a reduction in incident dementia. So that's a reduction in new cases per 5 years. We still have an increase in prevalence because of population ageing, and that's been attributable to better management of vascular risk factors such as hypertension, and also high levels of education in the population. Having said that, so that's been found in a number of high-income countries. It's not fully consistent. There has been a recent paper from the UK showing the reverse effect, and it was also gender specific in one of the UK studies. So it occurred in men but not women. We've also seen a really interesting study in the United States in the stroke belt, where they had big public health campaigns to address vascular risk factors, and they saw a reduction in incident stroke. So we are improving, and we've made incredible progress in managing heart health, and that is being reflected in better brain health.
Right. Roy Tasker asks, any evidence of everyday exposure to toxic chemicals, for example, PFAS, important?
I really love that question. I've been interested in toxic chemicals for a long while. We don't have a lot of data. So we do have data now on pesticides. Exposure to pesticides increases the risk of Alzheimer's disease. There's now systematic review evidence on that. But as you can imagine, it's often difficult to obtain information on what people have been exposed to in these cohort studies. So it's an emerging area where people are starting to look at the different chemicals that we're exposed to in our daily life. I'm not aware of anything at the moment on PFAS, but there may be some studies out there. Yeah.
We have any other questions? If not, from my end, I would like to thank you for as informative lecture as I have heard, and to wish all of those who have listened to you that they are brain shrinks less than expected for their age.
Thank you.
Thank you very much, George, and thank you, Kaarin. Kaarin, of course, is our inaugural Social and Behavioural Science Prize winner, which is fantastic. And George was the keynote address at last year's forum. So we have a very distinguished panel. And I'm afraid I have to think that our audience is absolutely riveted by this, given our age profile. I certainly found myself ticking, crossing, and worrying all the way through this. It was terribly worrying to find that sort of from some of the graphs that it's already too late to do much about what was happening in midlife in my 40s. But you have at least given us some solutions or strategies. I think, and of course, I'm not going to join a yoga class now. I'll just keep very hard on my Pilates, but I would like to know whether Pilates helps or whether I actually have to go and lift weights. Kaarin, if you wouldn't mind just sorting that one out for me. I think all of this story is so fascinating because it's that broader general discussion that you brought to this social disadvantage and why it is that it's such a difficult conception to have people in general take seriously. It's not just those of us who are many of us who are well educated and possibly don't smoke, although possibly do drink. That it's not just those of us who should be worrying. These are population issues, which is so important. And I think that that's been really fascinating for me. And so you listen to all of these issues and you think, how should we as a society be coping? Because it is our problem as a society. And I think one of the problems that our society has had is that fracturing and just thinking about our own problems rather than thinking about everybody else's. So I found that balance a really helpful way to think about it. And if I may, I just will say that in early July, Michael Marmot, Professor Sir Michael Marmot from England, is going to be talking about social justice and health equity. I've asked him, he'll be talking from England, but of course he went to Sydney University. And I'm asking about these issues because perhaps there are things we can do. And Kaarin, I think the way you described it, you really are looking for help on the policy issues. So we need to be drawing the resources of our rural society where there are strong policy people and people with real experience to try and work out how we can make it clear that it's not just my terror of my own dementia, but the general issues which are going to be the ones which make or break our society for, like you said, 2054, 800,000 by 2054. So I'm going to hand over to Susan to close the issue, but I my personal gratitude and I think that of everybody else. Thank you.
Thank you, Christy. Thank you, George, one of our distinguished fellows of whom we're very proud for conducting the Q&A. Thank you, Kaarin, one of our fellows, and as we have said, winner of our inaugural award in the social and behavioural sciences. This will be broadcast on the Society's YouTube channel, and we look forward to a really enthusiastic uptake. Thank you all. Thank you to the audience. I can see that we've still got a healthy audience, and please make this YouTube recording known to anyone you meet. So good night. Thank you, and I close the meeting.